Diseases of the alimentary system. In this session, we will continue what we started in the last lecture. Today, we will discuss the diseases of the intestinal tract. First of all, the inflammatory lesion. Example of inflammatory lesions of the bowel is typhoid fever. It's an acute disease caused by bacteria called Salmonella typhi. It has an incubation period of 1 to 2 weeks, and the lesion is seen in the intestine and outside the intestine. In the intestine, the lesion is in the ileum, so it's in the small bowel. The bacteria invades the ileum and go and proliferate in the Peyer's patches. These Peyer patches are the lymphoid follicle, which are normally seen in the ileum. These Peyer patches become swollen, then the overlying mucosa is sloughed or become an ulcer. This ulcer is oval, with the long axis is in the direction of the long axis of the bowel. I mean, it's the oval and parallel to the long axis of the bowel. It's opposite tuberculous ulcer, if you remember tuberculosis from general pathology. This is the lesion in the intestine. Outside the intestine, there may be many other lesions. For example, the lymph nodes in the mesentery is enlarged, enlargement of the spleen, hyperplasia of the bone marrow, but this hyperplasia of the bone marrow will cause leukopenia, decrease in the white blood cell number with relative monocytosis. The monocytes increase in the number relative to the other types of white blood cells, and this is very important in diagnosis. Okay, remember this. We will say it again a few minutes later. Gallbladder will inflamed, and the bacteria may go and settle in the gallbladder, and this patient become a carrier. Some degenerative changes all over the body. I mean, in the liver, cloudy swelling, fatty change, and you know what is the meaning of this. Cloud swelling in the heart, some hemorrhages, particularly hemorrhage, small, very small hemorrhages in the skin, and muscle degeneration. What are the complications of typhoid fever? It is an ulcerating lesion in the small bowel, so the first complaint or the first complication is hemorrhage. Hemorrhage from the small intestine may cause melena. Sometimes this ulcer may be deep and cause perforation. Perforation causes peritonitis. And sometimes the extraintestinal manifestation cause toxic myocarditis, and this is very serious complication, meningitis, neuritis, nephritis, and the most important one is chronic cholecystitis, and here the patient is a carrier. How can we diagnose typhoid fever? For sure, blood and urine culture, but cultures at least appear after 3 days, so we want an immediate test. The immediate test here is Vidal test. Vidal test alone is not a diagnostic test, but the rising test is the diagnostic one. I mean, I do it today and record the titr. I do it tomorrow and I will record the titr. If the titr is rising, so this is diagnostic for typhoid fever. And for sure, blood count that we just mentioned, the white blood cells decrease in the number with relative monocytosis and lymphocytosis. The second infectious disease today is dysentery. What the meaning of dysentery? It means a diarrhea, tenesmus. I mean, you have to make an effort for defecation, and the most important sign is passage of blood and the mucus with stool. So diarrhea, tenesmus, and blood and mucus with stool. What are the causes of diarrhea? Many causes. Amoebic dysentery, we discussed amoeba in general pathology. Bilharzial dysentery, and we discussed bilharziasis in general pathology. And today we will discuss the third cause of dysentery, which is bacillary dysentery. Bacillary dysentery is an acute infectious disease caused by another type of bacilli, which is Shigella type. It is an acute non-suppurative pseudomembranous inflammation. It's caused by ingestion of contaminated food. The affected region here is the rectum and colon. So bacillary dysentery and all dysentery affects the colon. Typhoid fever affects small intestine, ileum. Okay, microscopically it's pseudomembranous inflammation. And you know what is the meaning of pseudomembranous inflammation from general pathology? What are the complications of bacillary dysentery? Toxic complications in all sites of the body: peripheral neuritis, arthritis, myocarditis. Intestinal hemorrhage is rare because the ulcers are usually superficial. Perforation also rare because the ulcer is superficial. Stenosis also is rare, and the very important cause here is rectal prolapse from the tenesmus. Rectal prolapse due to continuous straining during defecation. This is the shape of colon cut longitudinally, and this is the mucosa with this yellowish pseudomembranous colites. Now, a very important type of disease in the bowel, which is inflammatory bowel disease. Inflammatory bowel disease is a two main category or two main groups of inflammation, which is ulcerative colitis and Crohn's disease. Let's discuss first one, which is ulcerative colitis. It's non-specific ulcerating disease affecting usually the large intestine, I mean colon and rectum. However, it may affect all the GIT. It's characterized by remission and relapse. Sometimes the patient is very poorly in bad condition, and after a few weeks he will be as healthy as us. The disease affects young adults and more common in female. The cause is unknown. It is maybe immunological. Here grossly, I mean by endoscopy, there will be mucosal ulceration, and between the mucosa there is what we call pseudopolyp due to the elevation of the mucosa in between the ulcers. Ulcer is the breast, and between this ulcer and the other ulcer, the mucosa is elevated, causing what we call pseudopolyp. It's not an actual polyp, it's just elevation and of the mucosa due to edema and infection. Microscopically, it is usually seen in the mucosa and submucosa, and there will be many neutrophils inside the crypt called crypt abscess. What are the complications? The complication, sure, there are many ulcerations. So the complication is severe hemorrhage, bleeding by rectum, I mean. Sometimes perforation peritonitis, but this is very rare. Toxic manifestation, this is very important. It may affect any other site with extraintestinal manifestation like arthritis, uveitis, I mean inflammation of the in the eye, cholangitis, inflammation of the biliary system, and very important complication as this type of inflammation may proceed into carcinoma in 10% of the patient, and this is a very big percent. This is the colon, and these are ulcers, and in between pseudopolyps. Now, the second disease of inflammatory bowel diseases is Crohn's disease. Crohn's disease is a granulomatous inflammatory lesion, and you have to know that it is granuloma, not like ulcerative colitis. The site of affection here usually at the terminal ileum and proximal colon, although involvement of the GIT from mouth to anus is common. Okay, this is very important to know that it may involve any part in the GIT. What we have seen here, that there is inflammation affecting all the layer, not like ulcerative colitis that affects mucosa and submucosa only. Here the lesion is segmental, I mean the lesion in this part, and the adjacent part is very normal, and then another lesion, then the adjacent is very normal. So we call this skip areas, giving us what we call a couple stone appearance, like stone arranged above each other. This stone is diseased, another stone is healthy, this stone is diseased, and so on. The mucosa show longitudinal ulcers and fissures. Fistula. What's the meaning of fistula? Fistula means that there is opening between the colon or the ileum and another hollow organ, with bladder, with uterus, with vagina, with another lobe of ileum. So fistula is very, very common, and fissure very, very common in Crohn's disease. Fibrosis for sure, because the ulcer affect or the inflammation affects all layers. And we have here granuloma. It's granulomatous disease. Dysplasia is rare, so to proceed into cancer is very, very rare and not recorded, unlike ulcerative colitis. This is couple stone appearance, very, very nice example for stone arranged above each other. What are the complications of Crohn's disease? For sure, from the clinical picture, we can know what are the complications. Obstruction from fibrosis, fistula, as we said, malabsorption syndrome, multiple ulceration and unhealthy mucosa, perforation, peritonitis, very common. Amyloidosis, any chronic inflammatory lesion leads to amyloidosis. Carcinoma, very, very rare, and extraintestinal manifestation are rare. So let's compare between ulcerative colitis and Crohn's disease. This is very important table we have to study very well. Ulcerative colitis usually occur in large intestine from the name colitis. Crohn's disease affects usually small and sometimes large. Ulcerative colitis has usually cause bleeding per rectum, intestinal hemorrhage, but Crohn's disease usually manifests by intestinal obstruction. Fistula and fissures are seen in Crohn's disease. Extraintestinal manifestation are seen in ulcerative colitis. Crypt abscess is in ulcerative colitis. Granuloma seen in Crohn's disease. Fibrous thickening of the wall is rare in ulcerative colitis but is common in Crohn's disease. Incidence of dysplasia and proceeding to carcinoma is common in ulcerative colitis. Now let's go to appendix. What we have to know in appendix is acute appendicitis. What causes appendicitis? Appendicitis is caused by two main pathogenesis: obstruction and infection. Obstruction by hyperplasia, fecal concretion, parasites like enterobius, very common. Enterobius in children especially. Whatever the cause of obstruction, the appendix is obstructed, then overadded by infection, whatever the type of the bacteria. Types of appendicitis, we have to know the most a very, very mild type, which is catarrhal inflammation. Then it may be suppurative inflammation, then it may cause gangrene. Gangrene means cutting or obstruction of the blood supply, venous and arterial, due to obstruction. Venous and arterial supply to the appendix causes gangrene, and this is very serious condition. Complications of appendicitis: perforation, appendicular abscess, and this is common, fistula with anterior abdominal wall, or septic thrombophlebitis. Now, there is a very important entity we have to know, which is intestinal obstruction. It means complete obstruction of the intestine, either acute or chronic. What causes patients comes to the emergency with acute intestinal obstruction? All of a sudden, he comes with a acute abdomen due to acute intestinal obstruction. Very simple obstruction like fecal mass, ascaris swarm, strangulated hernia. This is seen in male in inguinal hernia, or female sometimes umbilical hernia causes the intestine to be obstructed. Intussusception, what this is intussusception? I mean a small part of the loop inserted into another part of the loop, just like socks. This is intussusception. Part of the loop enter in another part of the loop, causing obstruction here. This is intussusception. Volvulus, it means that the part of the colon, especially sigmoid colon, turns around its axis. It will go in a complete circle around its axis. Vascular occlusion by thrombus affecting artery or vein in the vessels affecting supplying the intestine, or paralytic ileus. Paralytic ileus, it is caused by infection or after operation. We know all we know in cesarean, for example, the patient shouldn't eat anything until we hear the peristalsis of the intestine. Why? Because after manipulation of and touching the intestine, the intestine become paralyzed, no peristalsis, and this is a type of obstruction. So don't eat or drink anything until the peristalsis come back, and this is called paralytic ileus. These are the causes of acute intestinal obstruction. Now, what are the causes of chronic obstruction? Stricture due to fibrosis, whatever the cause, Crohn's disease, peptic ulcer, whatever. Carcinoma of the colon, causing obstruction of the lumen of the intestine. Pressure from outside by tumor, for example. Hirschsprung disease, this is a disease caused neuronal paralysis of the intestine, and the patient, there is no peristalsis in this part because there is no ganglion cells, no peristalsis, so there is dilatation of the colon, causes paralytic obstruction and adhesions for sure. Now let's go to tumors of the large intestine. Benign tumors of the large intestine, we have to know that there are many types, like tubular adenoma, villous adenoma, tubulovillous adenoma. We have to know that villous and tubulovillous adenoma are precancerous lesions. Precancerous, they may turn malignancy. Okay. The last one is familial Adenomatous Polyposis coli. This is familial disease. It's inherited by abnormal gene, ABC, Adenomatous Polyposis coli gene. There is defect in this gene, so these patients have many numbers of polyps, and it leads early, again, it's precancerous, leads to carcinoma of the colon. We discussed this because some of the benign tumors are precancerous, as we said, villous, tubulovillous, and familial Adenomatous Polyposis coli. They may proceed to carcinoma of the large intestine. Carcinoma of the large intestine, usually seen in old age, usually in male. The most important site is rectum. Rectum is the most important site for cancer colon. It may be presented as fungating mass, like cauliflower polypoid mass, causing obstruction of the colon. It may be presented as an ulcer. It may be presented as a diffuse infiltrating mass in the wall of the colon, or by mass giving or secreting mucoid. Okay? The most important microscopic picture that we have to see, we have to know that the most important type is adenocarcinoma by its variants. Adenocarcinoma. This is annular, causing obstruction. This is the lumen, just obstructed by mass. Ulcer, ulcerating cancer colon. This is all this is cauliflower mass obstructing the colon. Now, the method of spread, like any other carcinoma, direct spread to the surrounding organs, lymphatic spread to the regional nodes, blood spread to the liver, lung, brain, and bone, and very important method here, which is transcoelomic. Again, Krockenberg tumor that we discussed in gastric carcinoma. Now, to summarize, what are the ulcers that may be seen in the intestine? In small intestine, let's review together what are the ulcers of small intestine. For sure, peptic ulcer in the duodenum, typhoid ulcer in the ileum, tuberculous ulcer in the ileocecal junction, Crohn's disease in the terminal ileum and uremia and malignant ulcers. Each one has a specific site. Okay, what are the ulcers of the large intestine? Now let's review. Amoebic ulcer, bacillary dysentery, as we discussed, bilharzial ulcer in the colon and rectum usually, ulcer colitis, tuberculous ulcer may be seen in the ascending colon, Crohn's disease may be seen in the ascending colon, uremia, and malignant ulcer. To summarize, what are the causes of bleeding rectum? You know, bleeding rectum is bleeding fresh blood from rectum. Review what we have said. Just like intestinal cause, like biles. You know what's biles? Hemorrhoids, fissures, dysentery. As we said, that dysentery is mucus and blood with stool. Ulcerative colitis, polyps, worms like ankylostoma, for example, tumors like cancer rectum. Sometimes it may be caused by general causes as hemorrhagic blood diseases, leukemia, and so on. Now, what are the causes of melena? Melena, it means passage of digested blood. Usually digested blood due to causes above the second part of the duodenum. Any cause above the second part of the duodenum may cause melena. Esophageal varices, gastric, you know, it's upper level. Gastric, duodenal ulcers, and cancer stomach. Thank you.